Hi everyone. We're very happy to have you all at this great Red Talk. Olivier, the floor is yours to introduce the session. You have to unmute your phone, your microphone, and you can start. Cool.
Can you hear me now?
Yes, thank you. You can hear. We can hear you, Olivier. You can start. Thank you very much.
Thank you. Good afternoon, everybody. We are happy now to welcome Judith Trotman. I'm some words of presentations of myself. I'm a hematologist in Dijon, in France, and a member of the scientific and the steering committee of the LYSA group. And I co-chair the subcommittee focused on Hodgkin lymphoma. Maybe some words, Paul?
Hi everyone, so good afternoon. I'm Paul Blanc-Durand. I'm a nuclear medicine physician in Villach Lyon-Raymond, Créteil, France, and I'm glad to moderate this session with Judith and Olivier.
Good. So we are happy to introduce Professor Judith Trotman, clinician, researcher focused on lymphoma at the Concord General Hospital and Sydney University, and committed to both Australian-based research and international collaborations. She is member of the Australian Leukemia and Lymphoma Group Scientific Advisory Committee and chairs the Low-Grade Lymphoma Committee. And among our many commitments to implement research findings into practice, Professor Trotman brought many insights and evidences of the valuable role of FDG PET scanning in lymphoma, and specifically in follicular lymphoma. Her interest in PET assessment in lymphoma emerged in France during a one-year internship in the clinical research unit of Hôpital Lyon-Sud in France. And indeed, she demonstrated the prognostic impact of PET response at the end of induction treatment in the PRIMA study, one of the largest clinical trial in follicular lymphoma study that was conducted by the LYSA. The results of this pioneer study were published in the Journal of Clinical Oncology in 2011 and were implemented in many guidelines. Since that time, she conducted many other regional collaborative studies in the field and recently published 2 distinct papers in Lancet Hematology in a duet with Professor Sally Barrington, reviewing the role of PET in the first-line treatment in both non-Hodgkin and Hodgkin lymphoma. So, dear Judith, we are all pleased to welcome you and eager to listen to your talk and on application of PET scanning in basal lymphoma, and obviously happy to benefit from your expertise in the field. Judith?
Merci beaucoup, Olivier. Can you hear me? All right? Oui? Bon. En plus, j'étais le FFI le moins efficace dans toute la France en 2010. Mais j'ai eu une expérience extraordinaire. And I look back with fond memories of my time in France and the willingness of my colleagues in Lyon, Bertrand Coiffier and Gilles Salles, to allow me to ask the question in PRIMA as to whether PET scanning was important. Now, I'm just going to see, let's try and get this sharing happening. Can you see the screen correctly, the full screen? Yep. Excellent. Okay. Because it doesn't seem to look quite right to me, but I'm going to share with you what I call PET pearls, and also in English what we call pitfalls or PET falls in the role of PET scanning, primarily in diffuse large B-cell lymphoma, and then also a little bit on my own pet topic of follicular lymphoma. Now, I do have a problem here because I can't advance the slides, so I'm just going to try and see if I can get my dear. I'm more than happy if anyone would like to, I might have to disable and then share again. Okay, there we go. So in terms of financial disclosures, I receive research support to my institution, Concord Hospital, from the following companies. So let's start at the beginning with staging of diffuse large B-cell lymphoma. And I guess the best current data that we have to support the central role of PET in staging DLBCL comes from this Canadian PET registry, where in PET-based restaging of more than 500 patients with limited or equivocal stage on CT scanning, more than a quarter of the patients stage was upstaged to advanced stage, and the vast majority of those who had equivocal findings were reclassified. And this accurate staging is vital in an area that supports the role of abbreviated chemotherapy for limited stage disease, as I'm going to show in the cases that I'm going to present. Now, this change in management that occurs is not explained wholly by upstaging, not explained wholly by the biology of stage migration. The magnitude of change exceeds the rate of stage migration, and this may reflect change in the planned therapy because of the improved delineation of disease extent after PET scanning, even when the patient remains within limited stage. And in this study, they identified that 40% of those who had planned to have combined modality therapy with CT scanning were reassigned to chemotherapy alone. And more than a quarter of those who had planned to have chemo alone were reassigned to combined modality therapy. And there's also a survival benefit that's been shown by the impact of PET and in staging of patients and identifying the true early stage patient population. And you can see the PET cohort in the red line on the Kaplan-Meier survival curve here had a 1-year mortality of only 6% compared to 14% in patients who had limited stage on CT scanning. But very much led by the work done by Michelle Menyon and other colleagues internationally, we're now moving beyond simple staging in the role of baseline PET. And we're starting to look at the role of metabolic tumor volume, the volume of tumor with FDG uptake hotter than a pre-specified threshold. Because there's been no doubt that over the past 10 years in diffuse large B-cell lymphoma, and you will recognize a number of French studies here as well, that total metabolic tumor volume is consistently prognostic. But each of these studies have used different thresholds of FDG uptake to include in the tumor volume, whether it be all voxels that have an SUV max greater than 4, more than 25% or 41%. I suspect that the easiest, quickest, and most reproducible amongst readers will likely be the winner. And I certainly welcome the comments from Dr. Durand at the end of this talk as to, how we can come on a reliable, consistent, and standardized approach to agree on the measurement of tumor volume, both in diffuse large B-cell lymphoma and other lymphomas. And I suspect the standards will be different depending on which histology we're looking at. And the leaders of this benchmarking exercise, Michelle Mignon and Sally Barrington, have worked to provide a benchmark data set with contours and tumor volume measurement supplies by which end users can test their ability to measure tumor volume. And this will enable us to standardize tumor volume measurement, not just for clinical trials, but also for clinical practice and various commercial software manufacturers. I think the most important advance that has been published recently in terms of tumor volume for diffuse large B-cell lymphoma has been this analysis done by the Petra Consortium, published in JCO this year. And they did a retrospective analysis of more than 1,200 patients across 5 studies. And they compared tumor volume with the traditional IPI and its individual components listed there. And then they grouped the patients according to the expected clinical outcome. The 10% at highest risk who were anticipated to have refractory disease, the 30% defined as having intermediate risk because of risk of relapse in the first few years, and then the 60% at lowest risk of relapse and most likely to be cured. And they applied an SUV4 as the cutoff threshold for tumor volume measurement, and determined that the best tumor volume relationship with survival was applying this cutoff of just under 310 mils. And when they applied this cutoff, they found that tumor volume was a better predictor than the standard IPI for both predicting progression-free and overall survival. And the 3-year overall survival for those with poor risk defined by tumor volume with a cutoff of 308 mils was only 60% compared to 66% with those with high-risk IPI. And then they went further and determined that the best index was what they defined as the International Metabolic Prognostic Index. And here you use metabolic tumor volume, a measure of disease burden, along with stage, a measure of disease dissemination, and age as continuous variable rather than a cutoff of over 60 years, but as a continuous variable reflecting the biologic reserve of the patient. And they identified this 3-year overall survival of only 52% in those with a high IMPI compared to 90% of those who were these 60% of patients who were low risk. And you can appreciate here the better separation of the overall survival curves with this IMPI. So I think this is something that we'll hopefully see some more of and see validated in future clinical trials. The other baseline PET characteristic that is reflecting sort of, I guess, the radiomics of the tumor, which was first published in patients with diffuse large B-cell lymphoma and is showing promise as a biomarker, is the maximum distance between 2 lesions. And you can see here this image from, presumably this is from Anne Segalin's study, where in 2 patients on the left there who have the same tumor volume of 550 odd mils, the patient with the short Dmax compared to the patient with the long Dmax. And in 95 patients enrolled in the LNH-073B trial, this Dmax was reported to be highly predictive of progression-free and overall survival in a score that combined tumor volume and Dmax together. And this was validated, this was confirmed in a larger group of 290 patients from the REMARK trial, where both tumor volume and Dmax were independent predictors of progression-free survival. And when you combine them together, you got better separation of both the PFS and the overall survival curves. So I think we're also going to see something from Dmax in the future. So what I'd like to do to illustrate the role of PET scanning in its delineation and its management of localized disease is show you two young patients who entered to my clinic in 2020. And clearly they're on different ends of the tumor volume spectrum. The lady on the left there had an isolated 3 centimeter left cervical node compared to the large 14 by 9 by 9 centimeter circumferential duodenal jejunal flexure mass of the woman on the right. So the 48-year-old who had the localized favorable disease with no B symptoms, a normal LDH, germinal center phenotype, who was MYC negative, I gave her 4 cycles of rituximab and CHOP and 2 doses of rituximab. She became PET negative after her 4th cycle, and I didn't give her any involved field radiotherapy. And the rationale for this came from the German FLYER study published a few years ago now, which showed a comparable, very high 3-year progression-free survival of 96% in patients receiving just the 4 cycles of immunochemotherapy, compared to those who received the full 6 cycles. And the important thing here with both showing such a high PFS was that there was a substantial reduction. There was only 70% of the hematological and 80% of the non-hematological toxicity of the 6 cycles, and the patients obviously finished their therapy much earlier. So conversely, my patient with bulky localized double hit lymphoma presented with a rapid onset of abdominal pain, night sweats, and some early weight loss. She had a raised LDH in this large mass you can see here, with an IPI of only 3 because she was young, but a very high NCCN IPI, and was double hit on FISH. So back in 2020, I chose to give her rituximab and dose-adjusted EPOCH for 6 cycles. But mindful of her very high risk, I plan to do an interim PET after both cycle 2 and cycle 4, and to review in our RCP, multidisciplinary team meeting, after each PET scan. So before I go on to discuss this case further, I just want to raise one further issue about the role of PET in staging diffuse large B-cell lymphoma. And that's to note that PET is highly sensitive at detecting bone marrow involvement. And while it may miss small cells or low volume disease, this doesn't actually change the prognosis or provide any evidence to alter treatment. So it would actually, in one study, was shown that it would need 70 patients with limited stage disease and a negative PET to undergo a bone marrow biopsy to exclude a single case of indolent lymphoma. So I and most people, I believe, internationally don't do bone marrow biopsies for staging of diffuse large B-cell lymphoma anymore. So moving now on to the role of interim PET, and this is where we move into tiger territory. So the most commonly used method to assess PET response in lymphoma is by measuring this SUV, the standardized uptake value, which is the activity of FDG adjusted for the patient's weight and the amount of tracer administered. And many factors will affect the reliability of SUV, including the timing between injection and the image acquisition in particular. There are also the impact of extravasation of tracer and partial volume effects, and the impacts which, of course, the physicists understand so well, but we as hematologists understand very poorly in terms of the data acquisition and the reconstruction parameters. Now, the 2014 Lugano classification, based on the Deauville criteria developed in France, the 5-point scale, compares the uptake in the hottest residual lesion with the uptake in 2 reference regions, the mediastinum and the liver. And this is independent of size and independent of which lesion was the hottest lesion at baseline. And the 5-point scale, effectively, on an interim PET for diffuse large B-cell lymphoma, it's very easy to identify the patients in complete metabolic response, those with a Deauville score of 1, 2, or 3. Now, this is where we get into trouble, is when we define partial metabolic response, because it's defined quite broadly as Deauville score 4 or 5 with FDG uptake lower than that of the baseline and regardless of size of the residual mass. And there has to be, I think, better determination and delineation of what is a score of 4 versus what is a score of 5, and to standardize this hopefully at the next PET and lymphoma meeting. But different groups have defined a score of 5 as being 2 times higher than the liver or 3 times higher than the liver, or the presence of new lesions. And in the interest of time, I'm not going to go through the lyric criteria, which aren't particularly applicable for PET imaging in diffuse large B-cell lymphoma circumstances. Now, when we do a more quantitative interpretation of the interim PET, and this was very much developed by Michel and Olivier Casasnovas, our chair today. The French were very much pioneers in identifying and defining patients who weren't responding by the percent reduction, what we call the delta SUV max from the hottest lesion at baseline with the hottest lesion at interim scanning, and they defined the best cutoff as being a delta SUV max of 66% after 2 cycles or 70% after 4 cycles. And there's no doubt that delta SUV max identifies patients with an inferior overall survival compared to non-responders using a visual assessment when we amalgamate a Deauville score 4 and 5. But not if you define it by a Deauville score of 5 alone, presuming we can get consistency in defining a Deauville score of 5. Now, the other challenge with this is that the proportion of patients assessed as being PET positive will depend on the method used. So after 2 cycles, different studies have identified that at least 1/3 of patients will remain PET positive when you apply a Deauville score of 4 and 5, but only 7%, a very diminishing number of patients if you apply a Deauville score of 5 alone, and about 14% the SUV max of less than 66%. Now, there are also caveats to using delta SUV max, and patients whose baseline SUV max is relatively low, less than 10, it's said that they should still be assessed visually rather than quantitatively, and patients who have a residual SUV max greater than 5 should be regarded with some suspicion as being non-responders, even if they've had a good delta SUV max. So the Dutch did this tremendous individual patient data meta-analysis of more than almost 2,000 patients who'd received R-CHOP or dose-adjusted EPOCH from 9 studies. And when you applied a Deauville score of 5, the hazard ratio for progression or death was almost 4-fold at interim PET 2 and 5-fold at interim PET 4. Now, the hazard ratio was slightly lower with delta SUV max cutoff of 2.5 at interim PET 2 and 3.7 at interim PET 4. But as I showed you in the previous slide, you will capture a higher percentage of patients if you use the delta SUV max cutoff. And the Dutch determined on this meta-analysis that the optimal time to identify patients who are responding is after cycle 2, irrespective of the reading method, whereas the optimal time to identify the non-responding patients is after cycle 4, either using a PET score of 5 or a delta SUV max. And for that reason, when I have a patient who I think has a high risk of having a poor outcome, I tend to do an interim PET after both cycle 2 and cycle 4. And they did a meta-analysis of a larger number of studies and patients, and essentially the pooled hazard ratio for a positive PET was a 3-fold risk for failure on the 2-year progression-free survival. And while the negative predictive value of an interim PET is very high, you can appreciate there that the sensitivity, the specificity, and the positive predictive value varies widely because of the timing of the scans, the PET interpretation method, and indeed the increasing heterogeneity of tumour biology that we're beginning to recognise in diffuse large B-cell lymphoma. Now, I'd like to address the LYSA studies in a little moment, but first I want to go to the only prospective phase 3 randomized study of PET intervention. And this is the PETAL study from Germany, where 860 odd patients with aggressive lymphoma, most of whom who had diffuse large B-cell lymphoma with advanced stage disease, were treated with 2 cycles of R-CHOP, and further management was assigned according to the French-defined delta SUV max of 66%. Now, the PET non-responders were randomized to 6 further cycles of R-CHOP, so 8 cycles in total, or either an intensive Burkitt-style-like salvage regimen. And the PET responders were randomized to 2 further R-CHOPs with or without 2 doses of rituximab. And interim PET was predictive of 2-year survival across all IPIs. But as you can see up here on figure B in the yellow curve, treatment intensification failed to improve either event-free or overall survival, although it certainly added to the toxicity for patients. Now, there was also nicely in the study, and I think this is one of the great take-home messages from the study that's influenced my clinical practice, is that there was no survival advantage to adding those 2 extra rituximab in patients who were PET responders at cycle 2. And so I stop after 6, and that psychologically is wonderful for the patient to be able to move on and start thinking about life after therapy and life in remission after 6 cycles of R-CHOP. Now, just recently last year, they looked at the issue of delta SUV max and the Deauville score cutoff in the PETAL study. And you can appreciate here that the patients in the green, the bulk of the patients who had both a delta SUV max of more than 66% and a Deauville score of less than or equal to 3 had an excellent event-free survival probability here. But I draw your attention to the significant minority who did have a delta SUV max of 66%, but who failed to get to meet the Deauville score criterion of being less than or equal to 3. So they had a Deauville score of 4 or 5, and probably the majority of them had a Deauville score of 4. And you can appreciate here on their event-free survival curves, their outcomes are actually not that bad compared to the very poor outcomes for the patients who failed to achieve either a delta SUV max or Deauville score criteria. And the delta SUV max approach here in figure A, you can appreciate with the much better separation of the event-free survival curve, outperformed the Deauville score 3 in terms of Deauville score cutoff of greater than 3 in terms of discrimination performance. And it's probably due to this high number of false positive decisions with the Deauville score of greater than 3. So now, and I'm hoping that Olivia will be able to make some comment at the end of this, because there are two very important LYSA IPET response adapted trials. Now, it's also important to acknowledge that neither of these trials were phase 3 trials based on PET response criteria. So the first phase 2 study really helped set the scene for the second GAIN study. And in 220 odd patients under the age of 60 with high risk DLBCL, they had treatment adapted after 4 cycles of chemo according to the PET response. And remember, when this trial was designed, we had the old IHP criteria. We were just living and learning PET scanning, adapting our PET response assessment. And these old IHP criteria, which predated the Deauville score, used the background tissue FDG uptake as the reference. And the important thing from this study is it sort of was effectively a nice pilot study for the GAIN study. Now, patients who were PET2 negative went on to have standard immunochemotherapy consolidation. Patients who were PET2 positive but then achieved PET4 negativity went on to high-dose methotrexate for a couple of cycles and autologous stem cell transplant. And the authors noted that they did have similar, not exactly the same, but comparable outcomes to the patients who were PET negative. And those who were PET positive on both interim PETs went on to receive salvage treatment and definitely had significantly inferior outcomes. But the important thing that was identified in this prelude study was that the quarter of patients who were PET negative on both after cycle 2 and cycle 4 using the old IHP criteria increased substantially to almost 80% when you use the delta SUV max criteria. And that has certainly helped us better select those needing an alternative to standard immunochemotherapy in the phase 3 GAIN study with 670 patients, which used effectively the same protocol but adopted the delta SUV max criteria. And here in the GAIN study, what was actually the phase 3 aspect of this GAIN study was the randomization between rituximab and the type 2 anti-CD20 monoclonal antibody obinutuzumab. And this GAIN study was a very important study that endorsed and validated the data from the Goya study that showed that there was no survival advantage to the use of obinutuzumab compared to rituximab. But once again, the patients, regardless of which antibody they used, the patients who had 4 cycles of chemotherapy, either ACVBP, so commonly used in France, or CHOP, and those who were PET2 negative at cycle 2 went on to have their standard immunochemotherapy consolidation and had an excellent 2-year progression-free survival of 90%. Whereas those who were PET positive at cycle 2 but then achieved PET negativity in cycle 4 went on to have high-dose methotrexate and autologous stem cell transplant. And again, they had, similar outcomes with a 2-year progression-free survival of 84% and an excellent overall survival. Whereas once again, not surprisingly, these patients who remained PET2 positive and PET4 positive went on to salvage treatment, but still had inferior outcomes. But the GAIN study certainly supports the concept that there may be benefit to intensification of therapy for patients who are responders who remain PET positive at cycle 2, but then do become PET negative after their 4th cycle. So I want to go back to patient number 2, my 54-year-old with the double hit DLBCL of the jejunum. And after 2 cycles of our dose-adjusted EPOCH, you can appreciate that visually it looks like her mass has reduced significantly in size, but certainly there hasn't been much reduction in the SUV max from 30 to 22. A delta SUV max of only 27%, but a Deauville score of 5. Now, I was in a real dilemma as to what to do here, because I was aware of the poor positive predictive value of early interim PET, and decided that because she'd had significant reduction in size, because I really didn't have many other therapeutic options available in my healthcare system 2 years ago, I decided to press on. But I certainly did prime the patient that if there was any early signs of progression, or and that we would also be repeating her PET after her 4th cycle, and it was increasingly likely that she would also follow up her chemotherapy with either radiotherapy or a plan B. Now, the same day that I saw this patient and counseled her about this, we actually had a woman in lymphoma webinar on the role of PET in diffuse large B-cell lymphoma. So instead of getting 1 second opinion, I actually ended up getting 39, and 39 attendees voted, and you can appreciate there that more than half of them agreed with just ploughing on with the rituximab dose-adjusted EPOCH with some radiotherapy. There was a very broad global audience, particularly with a high American audience. So some of them suggested we go straight on to CAR T-cell therapy, and you can appreciate the RGDP or RICE and autologous stem cell transplant options that were also favoured by a minority of participants. So after her 4th dose of our dose-adjusted EPOCH, you can appreciate that we've really had no impact on her SUV max, and indeed her disease was increasing in size and was progressing, and indeed she also started to get symptomatic from her disease. She failed screening for the Belinda CAR T study, and I alert you to the fact that a lot of these CAR T trials, patients who are rapidly progressing with the worst risk disease, often are not eligible for study because they don't think that they'll actually get them to the CAR T-cell therapy. She was refractory to IGDP and also to commercial CAR T-cell available in Australia, and died. So to summarize interim PET, it identifies chemosensitive disease with a high degree of accuracy. And when the interim PET is negative, that's very reassuring for the vast majority of our patients who obtain an interim PET. And it may enable an end of treatment PET to be omitted. It supports the omission of involved field radiotherapy in patients with limited stage disease, and supports stopping after 6 cycles of R-CHOP, omitting the last 2 doses of rituximab. It excludes the possibility of progressive disease, but in the absence of such, chemoresistance cannot be identified with sufficient specificity. And there are really no effective alternative treatments except for the suggestion from the LYSA studies that patients who are high risk and eligible for transplant or CAR T-cell therapy. Now, I'm just conscious of the fact, I'm just going to have a quick look. I can't see my screen here. I hope everything's all right, because I keep getting these little beeps here. Is everything fine? Okay.
Everything.
Okay, good. Sorry, I can only see my slides. So I'll just have to go back to the slide window, if I can. I suddenly had a little thought, oh dear, they're not telling me they can't see the slides or something. Okay, so the last thing I want to talk about is the role of, in interim assessment, is the role of dynamic risk assessment that has been developed by David Kurtz and colleagues based on circulating tumor DNA. And certainly with the limitations in interim PET, we really do need further development of dynamic risk with such tools as circulating tumor DNA. And they identified 2 patients here who both have a similar probability of survival at baseline, but one who achieved early PET negativity and resolution and low circulating tumor DNA, who does very well, compared to someone who fails to get resolution of the clearance of the circulating tumor DNA and remains PET positive. And they identified this continuous individualized risk index approach. And they developed this model, which is populated by clinical risk factors and event rates from 11 studies incorporating circulating tumor DNA. They then went and tested it on another 130 patients, and the predicted and observed risks for individual patients were within 5% of each other during treatment. So I do think we're going to see more on the role of circulating tumor DNA coming out of clinical trials. So now moving on to end of treatment PET, and I guess the largest body of data that confirms what multiple trials have shown, the predictive value of end of treatment PET after first line treatment comes from some 1,400 patients in the Goya study. And you can appreciate here that the overall survival probability is very high in patients who achieve complete metabolic response. But looking here in the red, it's not all dismal for patients who fail to achieve complete metabolic response. And patients with a positive end of treatment PET do have an inferior survival, but we do need to be aware of the false positives, because, you know, a quarter of them at least will not have had an event after 2 years. And the risk of false positive very much relates to the residual large soft tissue masses with inflammation or bony remodeling. And FDG uptake, I remind you all, is non-specific, and we need to consider infection and treatment-related or other inflammation. Here I have a patient who had residual FDG uptake at the end of treatment with a Doppler score of 4 in his stomach after treatment on the Polaric study. I repeated his PET 3 months later, and he was still Doppler score 4. So we went in and did a gastroscopy, and his biopsy was negative, and he remains in ongoing complete remission 4 years later. And I think it's important to consider rebiopsy, but it needs to be decided on based on the invasiveness and the feasibility of doing such a biopsy and the pre-treatment risk, as well as the second-line treatment options that are available in your health system for a given individual. I want to flag one particular situation where a Doppler score of 4 is common at the end of treatment and doesn't harbor a poor prognosis, and that is primary mediastinal diffuse large B-cell lymphoma, where very frequently we will see residual FDG uptake that gradually resolves on serial PET imaging. So this was a 21-year-old competitive swimmer who I gave 6 cycles of our dose-adjusted EPOC back in 2018, and you can appreciate, not so much here, but down here you can appreciate she still has a little bit of glucose uptake in her mediastinum at the end of treatment. Now, obviously, I really did not want to have to give consolidation radiotherapy to a 21-year-old female. So what we did is we repeated her PET 3 months later, and she was in a Doppler score of 3, complete metabolic remission, and continues to remain in remission. The final slide I've got to talk about the role of end of treatment PET is from observational study done in British Columbia, looking at the role of PET-guided radiotherapy in more than 700 patients with advanced stage disease over a 12-year period. Now, patients who achieved PET negativity were observed without any radiotherapy. Now, the quarter of patients who were PET positive were offered radiotherapy if it was feasible. Now, obviously, I alert all of you there to the selection bias that is inherent in this situation. Nonetheless, the patients who were PET positive who received radiotherapy, which was about half of them, they had a 3-year time to progression of 76% and an overall survival of 80%. Approaching those who achieved PET negativity, compared to the poor outcomes for the patients who did not receive radiotherapy. But I do have to alert you over the selection bias there. I think what was also really interesting was that those who were PET negative, who had originally bulky disease, had outcomes indistinguishable from those who didn't have bulk, despite omitting the radiotherapy. And this echoes data from the German Optimal 60 study. So it suggests that radiotherapy may well have a value in partially overcoming the inferior prognosis of patients who remain PET positive. And I just added in a couple of extra slides here and pertinent to CAR T-cell therapy. And I thought particularly valuable to add this because it's a slide from Lyon-Sud, from Pierre Sesquez. And what was interesting about this retrospective analysis of, okay, it's only 72 patients in the CAR T-cell era is a really good cohort. And they did PET at 4 time points: pre-leukapheresis, pre-infusion of CAR T cells, 1 month after infusion, and beyond that. And what was interesting is they couldn't see any difference in outcome dependent on patients' metabolic tumor volume there. But what they did notice was that it was the delta tumor volume after leukapheresis, so the change in tumor volume between here and here, that seemed to be associated with progression-free survival. So disease responsiveness is clearly an important factor in how patients will respond to their CAR T-cell therapy if their disease is responding prior to the CAR T-cell therapy. And they also showed that patients who had a high SUV max 1 month after their CAR T-cell therapy had inferior outcomes. And there are several studies now, several observational studies, real-world cohorts that suggest if your PET remains positive after CAR T-cell therapy, you're likely to have an inferior outcome, particularly if that Deauville score is 5. So another reason why we really need to standardize our definitions of Deauville scores. So to summarize a few PET pearls and PET falls in first-line treatment of diffuse large B-cell lymphoma, it's definitely the gold standard disease burden measurement modality, and it influences management beyond simple upstaging, the tumor volume of growing prognostic and hopefully therapeutic importance for trials stratification and therapeutic approaches in future in clinical trials. It's better than bone marrow biopsy at detecting bone marrow involvement. An interim PET has a high negative predictive value, but a low positive predictive value, which is better after 4 cycles of chemotherapy. And delta SUV max definitely has better discrimination than a Deauville score of 4 and 5. End of treatment PET identifies those for whom omission of radiotherapy can be considered. But a third of patients who remain PET positive will not progress. And so I do recommend RCP review and repeat biopsy if considering anything other than radiotherapy. And on behalf of all my PET colleagues, I want you to say, let's not shoot the messenger, because PET is not our main limitation here. It's the lack of effective salvage for patients who remain PET positive, that is. So I want to summarize, finish up for the last 10 minutes by sharing a few PET pearls and PET falls in follicular lymphoma. And there's no doubt that while people are a bit slower to come to the party and recognize the importance of PET and follicular lymphoma, follicular lymphoma is a universally albeit not uniformly FDG avid lymphoma. So 99% of patients with follicular lymphoma will have FDG avid disease. However, there may be significant heterogeneity in the SUV uptake, the FDG uptake of patients' lesions. There is definitely, just as there is in the DLBCL setting, superior staging accuracy, and that upstaging is really important because it helps us identify those who truly have stage 1 disease amenable to local radiotherapy. And more accurate staging also in this histology is resulting in better informed treatment choices and altered management, and is also associated with better overall survival. A comment about bone marrow involvement, and I think this is particularly relevant because of a publication I'm going to point out to you that I just saw in JCO today. Bone marrow involvement in follicular lymphoma occurs in, probably over 60% of patients. It's diffuse and it's often low volume. And there is no doubt that PET is less sensitive than bone marrow biopsy at detecting this involvement. However, given the limited sampling of unilateral bone marrow involvement and the focal uptake that we often see on PET scanning, I think if you are going to do complete staging, particularly in clinical trials, both investigations are essential. However, notwithstanding the value of bone marrow biopsy in the PRIMA PI study, who are an R-CHOP CVP pre-treated population, there is no prognostic relevance of bone marrow involvement as demonstrated on bone marrow biopsy in the gallium study with about 1,200 patients. And therefore, I think it's quite reasonable to defer bone marrow biopsy in patients with advanced stage disease, certainly when the therapeutic intent is to watch and wait, or omit it altogether if the results are not going to impact on your therapeutic approach. And I think the role of bone marrow biopsy in follicular lymphoma is very much in patients with advanced stage disease. My feeling is it's best limited to clinical trials, if at all. Sarah Rutherford looked at the impact of bone marrow biopsy on response assessment in the gallium study. And bone marrow biopsy results altered response by the Lugano 2014 criteria for 10 out of 213 patients who are in complete metabolic response. However, only 5 of those were definitely positive, and of those 5 patients with a positive bone marrow biopsy at the end of induction, there was only 1 progressive disease at 8 months. On the flip side, if you didn't use PET scanning and you only looked at the patients in a CT complete response, only 2.8% of them had a bone marrow biopsy altered response. So I think, bone marrow biopsy assessment was very little value adding to response assessment. And I'll be the first to admit I haven't actually read this publication. I saw it in the summary of the headlines of what's in JCO today, but in 580 patients in the US Clinical Trials Network follicular lymphoma studies, only 5 patients had a positive baseline bone marrow biopsy who had complete response on imaging and had a subsequent positive bone marrow biopsy. So they argued quite strongly that bone marrow biopsy was irrelevant to response assessment in 99% of subjects. And again, I think if we were wanting to use PET response adapted therapy, we weren't looking at things like molecular response in follicular lymphoma. I think bone marrow biopsy is not necessary, is no longer relevant to response assessment, both in clinical practice and arguably in clinical trials. So now I want to just highlight the role of end of induction PET status in follicular lymphoma. And the first study to demonstrate the progression-free and overall survival impact was our very crude retrospective analysis of the PETs that were performed by rogue clinicians like myself in the PRIMA study. And we found of 122 patients with a median just over 3.5 years of follow-up, you can see there was really good separation of both the PFS and, surprisingly, the overall survival curve here, which is quite something when you think of sort of median overall survival of patients with follicular lymphoma, potentially 15 to 20 years now. And this was, again, duplicated in a retrospective analysis of the Follow-5 study by Stefano Luminari, but we got also some really good, robust prospective study from LYSA, led by Jean Dupuy, in 111 patients with 2 years of follow-up. And so that's what motivated me to get the French and the Italians together to pool our data from these 3 studies. And what we did is we did what we called Follicular, and in 250 odd patients in whom we had good enough quality scans to have central review, we looked at these scans by 3 central PET reviewers and identified that the Deauville score cutoff of greater than 3 had much better separation of the PFS curves, and it was also a lot more reproducible by the 3 PET reviewers. And you can appreciate there the significant difference in progression-free and overall survival in the Follicular study. And then on the basis of the early PET data, I managed to convince Roche in their gallium study to do an early protocol amendment, and they made PET mandatory for at least 170 patients. And we ended up getting baseline PET and end of induction PET in almost 600 patients. Once again, from gallium, you can appreciate the rapid, deep and ongoing separation of the progression-free survival curves at that early time point of just 2.5 years after the end of induction, along with the significant 13% difference in overall survival at this early time point. And this has been borne out with longer-term follow-up and will be in our 7-year follow-up publication from the gallium study to be published soon. So there is, however, I believe, one pitfall in follicular lymphoma, and there's a lot that we need to work out and understand more about the baseline SUV max, because baseline SUV max in the Follicular study was actually inversely predictive of progression-free survival, which really shocked us. And perhaps we were so nervous about it, we didn't actually go and publish this data. We just presented it at ASH. But I feel more confident about it because it's been validated in the gallium study. And in some 549 patients who had baseline SUV max recorded, there was no difference in progression-free survival between those with the lowest and the highest quartile of SUV max. And, 2/3 of patients had a baseline SUV max of greater than 10. We had 74 patients with a baseline SUV max of greater than 20. And I remember in those 74 patients, only one of them had documented on biopsy histologic transformation. And thinking that the answer was not the baseline SUV max, but the heterogeneity, the intra-patient heterogeneity in SUV max, we looked at that, but unfortunately that too was not predictive of outcome. So we really concluded on the basis of the gallium data that rebiopsy to exclude histologic transformation based on SUV max alone, as opposed to based on clinical features suggestive of transformation, may provide little benefit in de novo patients with high tumor burden disease. Conversely, total metabolic tumor volume was shown to be associated with poor survival in the Follicular study, and the using the 41% SUV max threshold method, you can appreciate here that the 1/3 of patients down here who had a high had a high tumor volume had an inferior progression-free and overall survival. So this was in a predominantly CHOP-treated patient population without much use of rituximab maintenance. So we wanted to validate it in the setting of the gallium study, where most patients were treated with immunochemotherapy using bendamustine, and all patients received antibody maintenance. So we were somewhat disappointed that regardless of the SUV max threshold that we used, we couldn't identify tumor volume as being associated with progression-free survival. And while when we did automated tumor volume with this novel deep learning method, with region-specific 3D convoluted neural networks to extract the tumor burden features from the PET scan, while whole body assessment of tumor volume was very quick and had excellent agreement with manually defined tumor volume, it was predictive of progression-free survival, akin to the use of bulk greater than 7.5. But you can appreciate there that while it is predictive, there isn't a huge separation of the progression-free survival curves. So there's still some work to be done, not just in SUV max, but in determining the impact of tumor volume with modern immunochemotherapy and maintenance approaches. And what I was really impressed with was some data that came from Kartik Nath from the Gandhi Laboratory in Queensland, trying to resolve this apparent conflict in quantitative PET data in follicular lymphoma. And what they did in these patients is they actually did their PET scan before they did their biopsy. And in excision biopsies, they assessed the immune gene infiltration by nanostring, T-cell receptor repertoire, and cellular glucose uptake. And they concluded that tumor volume is reflective of the malignant B-cell burden and is inversely associated with T-cell infiltration. And these CD4 T follicular helper cells and the activated cytotoxic T cells were clonally expanded in low tumor volume states. And it's these intratumoral T cells that were very glucose avid. And they argue that the differential influence of these intratumoral T cells on PET parameters will impact their predictive utility across different treatment regimens because they vary in the extent of T cell depletion they induce. And here's just in my final slide here, a slide showing the lower glucose uptake of the B cells compared to the cells, but reminding you that because there is far higher B cell contribution to the tumor, they contribute most to the overall glucose uptake. And I would really love anyone in the world, it would be wonderful if someone could go and look at this data and see whether it can be replicated in other clinical trials. And with that, I just want to reflect that while PET is the gold standing imaging modality for lymphoma, there are differences in patient populations and timing of scans. Our therapies are constantly evolving, and there are technological developments in PET scanners, and we are making headway in standardization of PET interpretation, and that certainly makes PET adapted decision making quite complicated. And I think there's an important role for the multidisciplinary team assessment of your interim PET scanning in particular. And with that, I want to acknowledge my colleagues in the Australasian Leukemia Lymphoma group, my wonderful colleagues from LYSA listed there, Gilles, Florence, Michelle, and Anne Segaline, and also Stefano Luminari and Massimo Federico from Phil, and my UK hematology and PET colleagues. I want to thank you all for being so interested in PET, and I leave my email there for any of you who might be interested in a year's lymphoma fellowship in the beautiful city of Sydney. And I'll end my show there, and happy to take questions. Oh.
Thank you very much, Judith, for this very nice presentation about PET for lymphomas at staging, follow-up, and interim PET. We have already some questions for you. First, the first one would be about the poll that you did and the early response of the patients that were not responder. Would you now consider using bispecific or CAR T cells for those patients?
I certainly would. We're really excited by our bispecific antibody responses, as I'm sure you all are over there when you use them. And it's a lot easier to organize for the patient than CAR T cell therapy. So we would be putting them, moving them straight onto one of our bispecific studies now. Yeah. Otherwise, if we couldn't get them onto a clinical trial, we couldn't get them to CAR T cell, certainly in Australia, we would have to use, I would have escalated her. And, hindsight is a wonderful thing. I wish I had escalated her and taken her to high-dose methotrexate and transplant, earlier. But it's a big move to make after only 2 cycles. And I think we mustn't, as has been shown from the LYSA studies, there is a role for high-dose methotrexate and transplant in those slow responders. I don't think we should all be necessarily stampeding to CAR T cell therapy for these patients quite yet until the data's out. But I would value what Olivia has to say about that.
To follow up, maybe with just say regarding autologous stem cell transplantation, we shown effectively in the GAIN study that patients with who are slow responder and positive PET with delta SUV assessments, but we will complete the response after 4 cycles with a negative PET of 4 cycles. These patients, when they are transplanted, have a similar outcome that patients with double negative interim PET. So I think for this group of patients, probably we need not to implement CAR T cells in this group of patients. It's not the same thing for patients with PET4 positive patients who have a poor outcome, even when we attempt to give them a salvage therapy and transplanted for those who achieve a response. So I think it's a small group of patients. It's about 15% of patients who are slow responder, but they were finally respond after 4 cycles of induction treatment. Probably autologous transplantation, intensification of chemotherapy is probably a good option.
Mm-hmm. And have you had a look at the biology of the disease, or once you start looking in the GAIN study and start separating out your double hit populations, they're getting all pretty small numbers, yeah?
It's these analyses are ongoing, but we have some data regarding mutational profile and also double hit, but we have only fish results in about half of the populations on the world. So we're currently analyzing this data, but I have no results and to provide you today.
Mm-hmm.
Judith, thank you very much for your excellent talk and complete on diffuse large B-cell lymphoma and follicular lymphoma. I would like to ask one question. Do you have definitively abandoned or bone marrow biopsy in these two lymphoma entity at baseline, or do you still perform a bone marrow biopsy in some subset of patients? What is your feeling?
I still perform a bone marrow biopsy to confirm the patient I think has limited stage follicular lymphoma, who I want to give them local radiotherapy. To be sure. But otherwise, I don't. And, you know, I know I disagree with people like Gilles here, but I sort of think, what's the point outside of a clinical trial? You know, what I'd love us to do, if we can get better at determining molecular response, and you know, we can get better at identifying molecular marker for everyone and can work out our compartmental issues, because we do know that from in the gallium study, when we looked at you know, Christian Potts looked at metabolic response as well, molecular response as well, and they found a molecular marker for about 3/4 of the patients. That was, you know, highly predictive of outcome, and in combination with PET scanning, you know, that might be what we have to be doing for the holy grail for, you know, the really young patients who we really want to be trying to get, you know, deep, you know, CCMR, you know, complete metabolic remission, complete molecular remission, in terms of trying that holy grail to try and cure their follicular lymphoma. You know, then things like bone marrow biopsy is obviously going to be very important. But otherwise, I just don't see the point. And I think it's going to be very, very hard. You know, I want to go and have a good read of the Rutherford and Leonard paper in JCO. Is it's going to be very hard to argue that we should be doing these biopsies in clinical trials. And it wouldn't be wonderful if we could get rid of them.
Okay.
Thank you. And to follow up with this question, we have a comment of Florence Brousset. Who writes, is it time to revisit the Chisholm 2014 response criteria to exclude bone marrow biopsy from screening and end of treatment in case of baseline positivity, so that the registration trial and a large number of trials won't require this assessment anymore?
It would save us a lot of money, wouldn't it? And a lot of pain for the patients and a lot of time for our trainees. Mm-hmm. Yeah, and I think that's something that we really need to discuss at the PIL meeting and come up with, you know, a consensus conclusion, whether that influences people designing clinical trials, whether the FDA is, you know, satisfied. I'd like to hope that there will be. I think the other thing that we really need to do, I think what we really need to do is work out, you know, our cutoff criteria for Dover score 4 and 5. I think that's really important. And even if it's not exactly right, if we're all slightly wrong in the same way, then that'll be better. You know, I think standardization is really important. The other thing that we really need to do is look at the role of PET with modern, you know, active immunotherapies, and you know, you will know better than any of us, in particular in Hodgkin lymphoma. We've all got those patients who've had a wonderful clinical response to pembrolizumab, and who, you know, have PET progression but still remain in clinical remission for a long period of time, whereas others have PET progression and get symptomatic progression. You know, it's very, very poor predictor and very hard to tease out. And I think the data is looking reasonably clear for CAR T-cell therapy, but we needed enlarged prospective CAR T-cell studies before we can be, absolutely certain of the role of PET and CAR T-cell therapy.
Thank you. One other question from the chat from Catherine Teblemont in Paris, Saint-Louis. Dear Judith, thank you very much for your fantastic presentation. Would you consider now bispecific or CAR T for early bad responders?
Yes, but I definitely would, and we do. But the difficulty is going to be, firstly, I can't do it in clinical practice, and I don't think you can either at this stage. The problem is going to be the definition of the bad responders, the early bad responders, because you don't know who the early bad responders are who are going to still be bad responders until cycle 4. And this is the problem with the low positive predictive value. So it's, hindsight is a wonderful thing, but when you're faced with that, what would it be, about a third, more than a third of patients who are still PET positive after cycle 2, we need to know which of the, the 70 or 80% of that population who are going to do badly, and which are the ones who are going to become late responders. So I think we have to get, from your studies and all these studies, we need to try and work out, of these patients who are PET2 positive, how can we identify those who will become PET4 negative? And I don't think we've got the answer.
Okay.
Maybe it's circulating DNA and biology, and that's where, because she was double hit, maybe I should have jumped after cycle 2.
Okay. Mm-hmm.
So we have also another question from Bertrand Adel. So from the PET expert viewpoint, how do you see ctDNA's place in monitoring or dynamic or not?
Sorry, I'm getting a lot of echo. What was the question about ctDNA?
It was how do you see it in monitoring?
I
don't know what the. How do you see ctDNA's place in monitoring, dynamic or not? Maybe Olivier.
I think it's probably because we, the three of us, have our microphones unmuted, but I just muted mine then. But I think I'm understanding, how do I sort of see how circulating tumor DNA is going to go. I have to be a bit careful here, but we're seeing circulating tumor DNA presentations from, David Rossi, from David Kurtz, from a few groups. But I think until we start seeing consistent, reliable, standardized, easily measured, rapidly available circulating tumor DNA data that we can incorporate into our clinical trials across, the 60 participating sites across LYSA, I think we're still a way off from being able to incorporate this into our clinical trials uniformly. It's very promising, but I'm getting a bit worried that it has been showing promise for years, but still is not showing we're not seeing it in large prospective trials coming out of multiple laboratories. But it should come eventually. Are you incorporating circulating tumor DNA analyses, just collecting it on an observational manner at the moment, Olivia, or are you actually incorporating it into your treatment algorithms and trials?
Today, I think few centers use ctDNA to monitor patients in clinical practice. Recently, I have a talk with Shalizadeh, and even in Stanford, they do not use the ctDNA to monitor patients in routine practice. So I think we need to work to probably simplify and make the technology more reliable to implement in clinical practice this approach in combinations with interim PET. And we have also a problem because we need to wait at least 3 weeks to obtain the results of ctDNA analysis. So it's not the clinical time to make decisions. So if you want to monitor patients, we have to perform the analysis after the first cycles and make the decisions after the second cycles.
Yeah.
Probably it's so.
I think that's, yeah.
There is still work, I think.
Yeah. And I think another little thing that's sort of not really ever discussed, but I like a picture. Patients like a picture. Patients like to see their before and after PET scan. And it's pretty easy to explain to a patient if they've got residual FDG uptake that, you know, you may need to change track. And it's very easy to reassure a patient when they become PET negative that things are going really well. I'm not sure a number is going to be as reassuring. I don't know.
Looking to the chat. I one more question for in the setting of follicular lymphoma. The what do you do when the end of induction PET is positive for a patient? Do you perform the maintenance, or do you proceed to salvage therapy?
Right. So at the moment, I enroll them all in Petrea, which I'm really pleased to do. So if they're PET positive, which is only, what, 17%, that's the other issue with, you know, the efficiencies of our therapies now. The PET positive rate is actually quite low. So if they're, you know, if they're PET positive in Petrea, they'll be randomized to rituximab maintenance or R squared. So let's say I didn't have Petrea. What I do is, if they're still PET positive, firstly, we've published, and it's quite a hard concept to understand, but if you have isolated mesenteric FDG uptake and no other FDG uptake anywhere else, and you don't have measurable disease on CT, your outcome is not actually as bad as if you've got measurable disease and you've got FDG uptake somewhere else. We haven't quite been able to understand that, but it's something that we definitely found in the gallium study. And I can't remember what Journal of Nuclear Medicine we published that in. And it's a bit of a hard read, but I think it's actually quite important. If you've got isolated abdominal FDG uptake, you might not do as badly as if you have FDG uptake outside of the abdomen. So if they have, if residual uptake, say in an inguinal node or an axillary node, I'll irradiate the heck out of it. Whether that makes a difference, I don't know, but it makes me feel better, makes the patient feel better. It's relatively low toxicity, and obviously I'm on with the rituximab maintenance in the hope that the rituximab maintenance will help, continue to deepen the response as we saw, in the PRIMA study, rituximab maintenance. We got more patients in complete CT response with the maintenance approach. But it's like preparing for Plan B, particularly if they're a young patient. I'm already starting to think, what am I going to do? And these are the patients who I will image, not with PET scanning, but with CT scanning, to monitor their remission if it's not easily monitored by palpation, because I'm wanting to detect early progression early to act on it. Because they have an inferior overall survival. I mean, this is really powerful data that we've shown from col and also gallium. You know, the more than 5-fold risk of dying in what is, you know, clearly no longer an indolent lymphoma for these patients. Whereas if they're PET negative, I'm very encouraging of no further imaging, and only imaging if they're concerned, and really try and, you know, let the patient choose for themselves if they want rituximab maintenance. And I really have to say that in the COVID era, I stress the risks of antibody maintenance and the toxicity of it. I really try and get them to sort of go away and try and live a life where, you know, they will be in remission for many years.
Okay, thank you.
So I think that was our last
Any other
so
question? I
no.
don't see any more questions on the chat.
Okay. Well, then if there's no further questions, I have to say thank you very much for the privilege of speaking. I'm sorry it wasn't in French. I think that would have stressed me out no end, and then you would have all been very entertained by my terrible Kiwi Australian French accent.
Thank you very much, Judith. It was an excellent talk and very brilliant, showing that we need to monitor patients in diffuse B-cell lymphoma and follicular lymphoma. And we will be happy to meet you probably in the next meeting, face-to-face.
I hope so. I'm looking forward to face-to-face meeting with you. And
we all thank you for your talk. Great talk. Thank you very much.
C'était un plaisir. Bonne nuit.
Thank you very much.
Bye.
Bye-bye.